about newborn infection, it's important that you know about the normal newborn, right? So we are going to do about newborn assessment. Okay. So when we talk about newborn assessment, we need to know why should we assess, when should we assess, and how should we assess. Okay. So the first one, why should we assess, is to save life, to reduce the neonatal mortality, to prevent disability. Can someone tell me when we should assess a newborn? When should we assess? What time? Are all newborn assessed in the hospital? Are many babies born in hospital or out of hospital? I need someone to answer.
Most are born in hospital.
Right, okay. So, do you know what percentage? Can someone...
Above 90%.
Sorry, I didn't catch that.
95%.
Right, more than 99%. So many babies, almost all are born in a healthcare facility. So these babies who are born in hospitals, do we assess all newborns? Do doctors do an assessment on all babies who are born before they go home?
Yes, madam.
Yes. So the next question is, when should we do this assessment? What time do you think is it done? Is it soon after birth? Is it done?
1 minute and 5 minutes for the APGAR score.
Okay, so soon after birth, one assessment is done. That is where the APGAR scores are marked. The APGAR score is not all, yeah. But does it have to be a doctor who is doing the APGAR score? Is it always a doctor who writes the APGAR score for a baby? Yes?
No, madam.
So who else can it be if it's not a doctor? Who else is present? Who are the other healthcare staff categories who may be present at the time of a delivery?
Nurses.
Nurses, yes. Who else?
Midwife.
Yeah, so who are the people authorized to do a delivery in our healthcare staff? To perform a delivery? Which categories? You mentioned 3, no? Doctors, nurses, midwives. Out of those, yes?
Doctors and midwives.
Very good, yeah. Nurses can perform provided they have what is called a midwifery training. Right? So doctors and midwives are the ones who are authorized to assist a woman at delivery or perform a delivery. Okay. So now coming back to the question. So the immediate assessment soon after birth will be done by one of the healthcare staff. So it can be a midwife, it can be a doctor, it can be a midwifery qualified nurse who does the first assessment. It's not necessarily a doctor. Right. So when would a doctor be there to do this first assessment? Are there special instances where doctors need to be there for certain babies' deliveries, or is it just as and when the doctor wants, he can come and he can go? How do you decide who is going to be there for whose delivery? Yes, you guys have done obstetric appointments too by now. You should have seen some deliveries. Are there specific deliveries where the pediatric team is called upon to stay or to be present? Or is it as and when they want, they come when they are free and have nothing better to do, they come for the delivery?
Preterm deliveries, madam?
Yeah, is it only preterm? You are correct. What do you call that category of deliveries where the pediatric team should be informed and they should be present at the time the delivery is done?
Higher risk?
Yes, higher risk or at-risk deliveries, right? So the obstetric team would identify those and pediatric team is called upon. One is preterm delivery. Can you give me some more examples? Other than preterm? What else?
Breech presentation?
Yes, good. Breech presentation. What else?
Growth restricted baby?
Yes, growth restricted baby.
Multiples.
Very good. Multiples. What else? Anywhere where the baby is perceived to be at risk, right? So even where there are maternal conditions like say diabetes mellitus, where the baby is at higher risk of having issues, maybe SLE, any problem with the mother, any complication in the mother and you are anticipating a problem in the baby, you will call. Also, if the CTGs or the fetal monitoring has revealed that something is going on with the baby. Right? And what about if there is meconium stain lico? When you do the ARM, you see meconium in the lico. Or even if there is spontaneous rupture of membranes, you notice meconium. So in that situation, we will be talking about meconium in more detail in the respiratory distress lecture. But meconium means the baby has been hypoxic, unless it's a post-term baby. Right? So it means that the anal sphincter is open. So unless it's a baby who is, at term, also a certain percentage of babies' anal sphincters might be open. But you have to think of the possibility there might be an episode of hypoxia. So it is any episode of meconium, any evidence of meconium, you should call the pediatric team in. Right? Okay. So there are instances like that where a doctor has to be there. The pediatric team is called upon. The decision should be made by the obstetric team, right? So there are identified at-risk deliveries or higher-risk deliveries where the pediatric team is called upon, right? So when they attend this, let's say, immediately after birth or the birth of a baby, what are the things that they should look at? What are the parameters? Yes? What parameters should be looked at in the baby to see whether the baby is okay?
Fetal heart rate?
No, when the baby is born, right? So it's no longer the fetus, it's a neonate. Yes, they have to look at the neonatal heart rate. So you don't need to count, but you need to check the rhythm. Okay? Can you hear that?
Yes, ma'am.
Okay, so that is the normal neonatal heart rate. It should be more than 100. But if you hear a rhythm like this, do you appreciate the difference between that and? Yeah? Do you hear that?
Yes, madam.
Okay, so the faster heart rate is what we want you to hear. If you are hearing something which is not that, something slower or not hearing anything at all, that means there's a problem. So good. Heart rate is one of the things that we want you to listen to. What else?
Skin color?
Very good. Skin color. Okay, so since we are now talking about these parameters, we can also maybe talk at the same time which ones are normal. So what skin color would make you happy and think the baby is okay? What skin color would you like to see?
Pink.
Pink, good. So if it is pink, like let's say we can talk about the APGAR score also at the same time, I suppose. APGAR score also has the same parameters. Okay, I will get to it in a minute. So pink would say the baby is okay. Right, what else? Skin color, heart rate, what else?
Crying.
Okay, crying. So crying is actually depicting something else. What is it? If a baby cries, we believe the baby is doing something. What?
Respiration.
Very good, yeah.
Breathing.
Sorry? Sorry, what did you say? Somebody answered, no, girl? Sorry, didn't catch your name.
Breathing, madam.
Yeah, breathing, yeah. So you're right. Previous colleague was also right. It's respiration, right? A good cry will tell you that the baby is breathing well. So 3 parameters you mentioned. Heart rate, breathing, by the way of a good cry, color, what else?
Temperature.
No, temperature is important, but the moment it's born, we are not going to check the temperature. We want to see is it alive or dead, to be very simple, right? Basically, if it is more towards life and if it's having very good signs of life, we say born in good condition, then we don't have to go and bother with the baby and try to resuscitate it. But if it is having issues where we say poor condition, then we have to resuscitate. So temperature is something we look at and it's important in the resuscitation thing, but it's not something we measure immediately. Okay, what else?
Whether the baby is mobile.
Yes. Okay, so you look at the tone, right? Is the baby in a flex position? Is it moving around? Right, so those are the things we look at. So when we assess, I'm going to, the previous question I asked, we assess at 2 times. One, we assess the baby at birth. Secondly, we assess the baby before discharge. Right, so now looking at this baby, what do you think? Based on the things you told me, do you think this guy is okay or do you think he's having issues? Can you tell me what do you think about the color?
Color is pink, therefore.
Yeah, but can you see in the arms and legs it's a bit blue?
Yes.
Yeah, but predominantly pink, you're correct. So I hope you have seen actual babies being born. Yes?
Madam, about half the batch has not done the appointment, but half has seen, I guess.
කිසිම obstetric appointment එකක් කළා නැහැ කියලා දව කියන්නේ.
Oh, madam, IVOG කරලා නැහැ.
Okay, but you got, because of this COVID business?
Yes, madam.
Oh, alright. That's a bit weird, but anyway. Okay, so the guys who have seen a delivery, can you tell me? Is the baby born nice and pink? Or does it have some blueness or grayness in it when it's born? Anyone who has seen? No one has seen. Has no one seen in your group? Can someone speak up if you have seen a baby being born?
I've seen one, madam, and that was slightly blue.
No one has seen. So, yeah. What did you see in the one you saw?
Slightly blue-ish.
Yeah, very good. Okay. So, like, this is what you will see. Okay. So, when you guys get to go to the wards, do wait until the baby is born and you will see the baby doesn't turn completely pink until it cries. It looks a bit grey and blue and off color. But it will cry within the first minute and after it cries only it pinks up. Right? So this is why the color in this picture. Right. What else can you see? You mentioned crying. We can't see the heart rate in this picture. What else can you see? Do you think this guy is crying? Yeah? Who says it's not crying? Or who says it's crying? What do you think? Can someone answer so we can get on with it?
He's crying
Is crying. Yeah, the mouth is open, no? He's crying. What about the tone? You talked about mobility earlier. How will you describe its tone? Do you think it's a flex tone or extended tone?
Flexed.
Flex tone, right? So these are the 4 main parameters we check at birth. We call them C, T, B, H. C for color, right? T for tone, B for breathing, H for heart rate, right? So looking at the given cell, looking at this picture, this baby appears to be in good condition, right? So those who have done the IVOG, I think I would have done a session regarding the ABGA score and temperature and stuff like that. Those who haven't done IVOG, you will be having a session with me during your IVOG as well. Right. So now if we look at the ABGA score, the name is because of the person who actually found this score, Virginia ABGA, an anesthetist, right? So one is the color, right? So we score this. The minimum score is 0 for any given parameter. Maximum score is 2. So what is the maximum ABGA score someone can get? There are 5 parameters.
10.
10. And what is the minimum score? 0, right. Okay. So let's go through one by one now. Appearance is color, right? So if the color is pink, you get full marks is 2. Nothing is 0. Middle is 1. Remember like that. It's easy. So if the baby is pink, you get 2. If the baby is pale or blue, you get 0. If the baby has pink body with blue extremities, like the picture I showed you, then the score is 1. Okay, any questions on that? How to score color? This you need to know thoroughly, right? Because midwives also know how to do this properly. Midwives, nurses, everybody else knows. Any questions on color? Okay. Then what about heart rate? Okay. So, right. Now that, where would you put that? Is that greater than 100? Yes. So then, how will you score that? 2. If you get a heart rate like this, oops, sorry. How will you score that?
You give 1.
You give 1. If you hear nothing, you give 0. Right? So this, don't take this first column of this, right? It is not pulse. You have to auscultate it with the stethoscope. The description is correct, right? You actually listen to the heart rate. We leave grimace for a minute because we don't actively assess that. Activity is what one of you said, whether the baby is mobile. So flexed is like the picture I showed you. All the, you know the meaning of flex, right? Arms and legs are bent. Flexed arms, flex legs. Loose and floppy is if there is no muscle tone, the baby will be just like a rag doll, right? So no flexion. The baby will be in extension. So if we look at the picture that I showed you, this picture, how much will you score? For tone?
2 marks.
2 marks, very good. So sometimes the baby will move just a little bit when you touch the baby, right? Then you can give some tone, or if there is a lot of no movement and the baby is laying lifeless, very like, hanging loose, it is 0. Right. Then about respiration. Again, if we go to the previous picture, how much will you give for this guy?
2.
2. Good. So if there is a good cry, he's opening his mouth a lot. So we would assume that he's crying loud and has a lusty cry. Lusty means big nice cry. Not like a something like that. It's like a very weak cry. You will get only a 1 if it's a mumble. If it is no cry, no breathing, it will get 0. Any questions on any of that? So grimace is, now when we are when a baby is born, we need to make sure baby does not get cold. So as one of your colleagues pointed out earlier, although we don't measure the temperature, we must make sure the baby doesn't get cold, right? When the baby is being born through amniotic fluid, so it's going to be wet. So we have to be ready with warm towels to wipe the baby. So when we are wiping the baby, we see what the reaction is, right? So the baby will move, he will try to kick, he doesn't like being wiped, all that. So that is when we actually check the reaction. We don't pinch the baby, right? This description is wrong. I have borrowed it because I thought this APGAR thing looked nice, but there is no pinching of the baby at all. We do dry and cover. We dry the baby with a warm towel, and while we are drying, the baby will react. If the reaction is a very vigorous cry or pushing or, doing something something strong, you say it's a 2. If it's just a mumble like, that's all you hear, hardly anything, you give a 1. If there's no reaction, you give a 0. Right? So in APGAR score, right, the 5 parameters are color, right? So color pink, you give a 2, color pale or blue 0, body pink, extremities blue 1. Right? Tone. Tone is where this one says as activity. Tone, if it's loose, floppy, no tone 0, good flex tone 2, moderate tone 1. Breathing, if there is regular breathing, good breathing, strong cry 2, weak cry, gasping 1. No breathing 0. Heart rate, the more than 100 is 2. That would be 1. Not hearing anything is a 0. And when you are drying, the reaction the baby is showing you, if there's a good reaction 2, no reaction 0, moderate reaction 1. Anyone who has any issues with APGAR score, because this you need to remember till the end, and most of the time you get it well. You need to know this in your real life work as well as you will be getting this at your finals also. Any questions? Anything you want me to clarify?
Madam, just one thing, that initial thing that you said, CTBH, is that the same thing as APGAR score, but that you do as soon as the baby is born, and APGAR you do at 1 minute, like that, or?
The same parameters, right? Now what happens is APGAR score is scored at 1 minute, 5 minutes and 10 minutes of age, right? So you don't wait until 1 minute without doing anything. The moment the baby is born, the baby is kept on the mother's chest and we wipe with the towels, right? The dry warm towels. Right? When we are wiping only, we check these. So in resuscitation, the same parameters are used, but the nomenclature we use is CTBH. So as part of, for every baby, you do the dry and cover part because you don't want the baby to get cold. Right? So color, tone, breathing, heart rate. Those 4 things, those are the 4 things we assess when we do the initial assessment. Same things are documented at 1 minute, 5 minutes and 10 minutes. And that is what is called the APGAR score. It's slightly different, but same parameters are used. It's just that the nomenclature is different. Is that clear?
Yes, madam. Thank you.
Because at the moment the baby is born, now when you all go to the labor wards, whenever you all go, there is a stop clock in the resuscitator. Most of the time, it will be known as the APGAR button. So the moment the baby is born, we press that. And at 1 minute, when you read the scores, you say it is the 1 minute APGAR. At 5 minutes, when you read the scores, it is the 5 minute APGAR. At 10 minutes, when you read the scores, it is the 10 minute APGAR, right? That's how you know the time. So any questions based on this part? So this is basically the initial assessment. But you don't have to wait for the APGAR to think of resuscitation, right? You have to score the APGAR as part of our documentation. But as soon as the baby is born, not even at 1 minute, we look at the CTBH to see whether the baby needs resuscitation or not. Resuscitation is, do we need to correct the airway? Do we need to give breaths? Do we need to give chest compressions? So for that, we don't wait for 1 minute. As soon as the baby is born, we are checking it, right, for every baby. And then based on that, we will start resuscitation. But we need to document the parameters at 1 minute, 5 minutes and 10 minutes for documentation purposes. That is not for action purposes mainly. I hope I am clear. Any questions? Yes. APGAR score, you don't score like that. That's why I said it's for documentation to maybe to compare and see, okay, so what's APGAR of something. You don't say anything is normal. I mean, maybe you can say 9, 10 would be fine. But initially, before saying normal, before you come to the APGAR score, you have to check the color tone, breathing, heart rate as soon as the baby is born. So in that, what will you say is normal? Color should be pink. All the twos. Color should be pink. Tone should be flexed. Heart rate should be more than 100. And baby should have a good cry in the CTBH. Right? So therefore, because most of the time in a normal baby will have, peripheral cyanosis, meaning the body is pink, extremities are blue. So at 1 minute, APGAR will most probably be 9 in many babies because of the one that you get for that. But everything else should be a 2. So therefore, if you want to really say normal, it will be 9 or 10. Right? But you don't wait for the 1 minute. As soon as the baby is born, that is why I mentioned the CTBH. You go on with the CTBH. But at 1, 5 and 10, you document. You don't do action based on the APGAR, you do action based on your CTBH because you do that sooner. Okay. So, what about this baby? What about color? If you look at CTBH, yeah? How many marks how will you grade the color in this one? Yes? Come on.
Zero.
0. It looks well blue or pale. It looks very odd color. Right. Then, what about tone?
0.
Do you think he's flexed? Yeah, 0. No tone, very floppy baby. Right. Then what about breathing? A bit of pain there. Do you think it's crying?
No.
No. Yeah. Right. So this one, heart rate we can't hear. So see, there's a big difference between this guy and this baby. Right. So this baby is one born in poor condition. Right. And this baby, CTBH is also indicating it is not good because it's not pink, no flexion, no crying, right? And so this baby will definitely need resuscitation, whereas the previous one will not. And the APGAR scores also when you record will be poor and low in this one. Okay, so if the baby is born in poor condition, that means baby is not pink, baby is not, the tone is not normal, baby is not flexed, heart rate is slow or absent, baby is not breathing, we need to do what is called neonatal resuscitation, meaning we are trying to breathe for the baby. So these are some of the gadgets that are used. We will get into detail of how to do the resuscitation when you come for the final year appointment, right? Right. So now I'm going to move to the babies are assessed at 2 time points. The first assessment is soon after birth. That is not done always by a doctor. That can be done by a midwife or by a nurse or by a doctor if the doctor has been called, right? So if there is a problem, the doctor will be summoned. If there is some problem with the baby and resuscitation is required, again, nurses and midwives are trained to do the basic resuscitation. So they will initiate the resuscitation and get the doctor also to come and sort out the problem. Now the second examination, right, is done before baby is discharged. The second examination has to be done by a doctor. So every baby has to be checked out or done a screen by the doctor. So before the baby is examined, so you guys need to know this thoroughly as a house officer in a general hospital, say not at DMH or Castle because they are specialized maternity hospitals. We don't have house officers, we have MOs, but everywhere else, right, the neonatal examination is done by the house officer. So before we touch any baby, we have to wash our hands, right? We have to get consent from the mom, talk to her, introduce yourself, say you need to check the baby, right? And before you touch the baby, you have to obviously do the inspection, the observation, and you must make sure, because you might need to remove their clothes to check them out, you must minimize the time of exposure, and you must not keep them under fans or ACs or anything like that, because they are going to get cold, right? So washing hands is very, very important, right? Because hands are the predominant reason for giving infection to everyone, especially newborns. So if you are asked what is the most important step of preventing infection in neonates, it will be washing your hands. Right. So once you wash the hands and you talk to the mother, there are a few things we need to look at. We have to look at the color of the baby in the central areas, lips and all, and then the hands and feet for peripheral cyanosis. Not only for cyanosis, we also have to look for jaundice or yellowish discoloration. Right? That is best done near a window or someplace where there is natural light. Then the posture is, we already talked about it, whether the baby is flexed or not. How is the tone? Is the baby moving? If the baby is moving, is there symmetrical movement? Is he moving all four limbs? And is he breathing? What is the respiratory rate? And is there increased respiratory effort? Meaning, are there recessions? Is there grunting? And is there nasal flaring? Right. So looking at this baby, what do you think about the skin color? You guys need to respond fast, otherwise this is going to get dragged out.
Yellow.
Yes, good. So this is a baby who looks very yellow, right? So if you see any sort of yellow, this baby will need a serum bilirubin, right? Okay, so we are looking for jaundice. What about this baby? What about the color in this one? Yes? Anything? What is it?
More red.
Sorry?
More red in their hands.
Is there any cyanosis that you can see? Around the mouth and in the hands there is some cyanosis, right? Lips are pink, but there is some perioral cyanosis and peripheral cyanosis also in the hands. Right? Cyanosis, this is how it comes. So it may be that the baby is cold. The commonest reason for peripheral cyanosis in a neonate is that it's cold. What about this picture? You can see the foot, the close-up picture of the foot. What can you see? Come on.
The toes are
The toes are purple, yeah, or it's blue. So there is some degree of cyanosis here. When you see this, you should check whether there is central cyanosis also, and you should check the saturation, right? Okay, what about this baby? This is a local picture, one of our babies actually. May be difficult to detect, the lips are dark color, right? This is a baby with a cyanotic heart disease. So this baby's lips are actually cyanosed. Okay, what about this guy? Are you happy with the color? Is there any jaundice, any cyanosis?
No.
No. So he's a pink baby, okay? So he's pink. Right. So you look at the color. We saw several pictures on color. We look at the posture. We look at, is the baby moving all four limbs symmetrically? If they are not moving, it may mean that, they can have fractures while being delivered. So you have to look into those things. Then we had to look at respiration, the rate, and whether there are recessions, grunting and stuff. So we'll talk more about respiration. Can someone tell me what is the normal respiratory rate in a neonate? Yeah, it is between 30 to 60 breaths per minute, right? Much faster than us. Right, so we will talk more about respiration when we talk about identifying respiratory distress, because you have a lecture on respiratory distress. Right, so we check for respiration, we check for posture and tone, we check for color, and then we undress the top part, the shirt. And then before the baby starts to cry, we should auscultate. What are the common heart diseases you expect to find in a neonate? Think of the congenital heart diseases, common ones. Can anyone remember any names what you learned under congenital heart diseases with the cardiovascular module?
VSD.
Very good. Where do you hear the murmur? Where do you hear the murmur in VSD? Is it what sort of murmur is it? Can you remember those things?
The systolic murmur.
Good. It's a pansystolic murmur heard best where?
Apex.
No, not in the apex. You hear it in the left sternal ledge, around 3rd to 4th intercostal space, right? Okay, so like VSD, what else is there?
Tetralogy
That's not common. Think of the left to right shunts, those are the commonest. Like VSD, what are the other two like VSD? VSD is ventricular septal defect. What is the other septal defect?
ASD.
ASD, atrial septal defect. Where do you hear that best?
The pulmonary area.
Yes, so it's in the, you can hear that again in the left sternal ledge, around 2nd intercostal space, right? So when you keep your steth in the middle part of the left sternal ledge, if you cover 2nd to 4th, you will be able to hear ASDs and VSDs. What else is there? What is the other common murmur you hear in small children? Left to right shunt, VSD, ASD and?
Patent of the
Yes, good. Patent. Where do you hear the murmur? Left intraclavicular, right? So it's in the left intraclavicular area. Again, it is a pansystolic or continuous murmur. So these are the places where you need to keep your step when you are examining the newborn. Because if you try to meddle too much, they are going to cry and shout and the whole thing will be over. Right? So you have to be tactful and quick. So you keep your step over the left sternal ledge, covering 2nd to 4th, so you can hear ASD, VSD. And you keep it under the clavicle on the left side. That is the intraclavicular area on the left side to hear, listen to the PDA. Right. So once you do that, then you auscultate under the 2 axillae to listen for air entry and to see whether air entry is equal. Because that is where you can hear all the zones of the lung converging. Once you do that, then you start palpating the abdomen. Yeah, I have put a bad picture here without realizing, because this person is having the watch and rings and so many things. You should not have any of those things. You have to remove the watch, rings, everything when you are examining the baby. So abdomen should be palpated like anyone else from the left side. You palpate for the liver, the kidney, the liver, from right iliac fossa upwards to the right hypochondrium. Right? Like that. Then diagonally from right hypochondrium to the left hypochondrium for spleen. Then you have to ballot both sides for the kidney. Right? So that is palpation of the abdomen. No superficial deep palpation, no looking for fluid. If these things are positive, then you will have to do a full examination. Otherwise, liver, spleen and kidneys will suffice. Right? Then we have to have a look at the cord. Right? So you can see here, that is special thing in a newborn. You have to see whether the umbilical cord is healthy or not. We look for 3 things. We look for pus, blood and periumbilical erythema. Right? So periumbilical erythema means the surrounding area around the umbilical cord, where it is attached to the abdomen, whether there is redness in that or not. Right. So the umbilical cord should be kept always out of the nappy. You should not put the thing inside and put the nappy. It should be outside. We don't want it contaminated with urine or stool. Right? And you can see the umbilical cord is there. It looks very fresh soon after birth. It dries out. You expect it to fall. It will be like this at about 7 to 10 days. It will fall. Right? And the area will heal. So what do you think about this baby? Is it healthy umbilicus? Or is there a problem? Yes? Healthy or not? I need someone to answer soon.
No.
Why not? What is the problem in the umbilicus? Yes, someone said no. What is the problem? Did you identify anything? So is there any pus or blood you can see? Is there pus or blood?
Yes.
Where? There is no pus or blood. May පාට කහ පාට වෙනවා. It kind of becomes this off color after a while. This is normal. Right? This is a normal umbilicus. And there is no periumbilical erythema. It's nice and clear. So that's a normal umbilicus. Look at that. Can you see pus here? Yes or no?
Yes, madam.
Yes,
Yeah.
madam.
Now this is pus, right? If you see like this, it's a problem. That is what you call pus. It looks very unhealthy also. What about this? This is blood inside. Okay, and there is some redness surrounding area also. Okay, so these two pictures are showing you unhealthy umbilicus, whereas this one is showing you a healthy umbilicus. Okay, so once you do that, you can turn the baby around and look at the back. Right? You have to palpate the whole spinal cord. What do you call this? You have to look for, what is this called?
Meningocele.
Yeah, it's a meningomyelocele. We are looking for any sort of spina bifida. There can be, tufts of hair, lipoma, hemangioma, anything. Any odd thing on the back, we have to make note and investigate further. What is this? We also look at,
Sinus tract.
that's right. So we look at the sacral dimple. There's a depression in everybody, but here you can see there is it may be a sinus tract. There seems to be a little bit of hair as well. Hemangioma, it can be a sinus tract, it can be a tuft of hair, it can be many things, right? So it needs to be investigated. What is this? This is a hemangioma. Right, so that may mean there's a spina bifida occulta. So we'll have to do a scan and see whether there is any connection down, extending down to the spinal cord. Right, so now you put on the shirt and you remove the nappy. So do you remember the things we checked? We checked auscultated for ASD, VSD, PDA. We looked for air entry under both axillae. We check the abdomen for liver, spleen. We ballot for kidneys. We check the umbilical cord. We turn the baby over and we can check for the back as well. And then after that, so there we saw different pictures showing tuft of hair, hemangioma over the back. They are all indicating spina bifida occulta, or there can be meningomyelocele. So once you check all that, you put back the shirt and you remove the nappy. Once you remove the nappy, you have to check the genitalia. Right? In boys, you have to check whether the testes are present. That is what is being done here. In girls, we have to check whether the labia majora, or generally they will be covering the labia minora. So this baby looks like a preterm, where you can see separately the labia majora, labia minora and the clitoris. And you can see a little vaginal tag kind of thing also. So types of hypospadias, right? You have to look at the placement of the urethra to see whether there is epispadias or hypospadias, right? And if there is hypospadias or epispadias, surgical referral will need to be done later on. Right. So you look at the genitalia for testes, placement of the urethra, and for ambiguous genitalia. right, which will indicate what will ambiguous genitalia indicate in a baby? What condition are we thinking of?
Benign adrenal hyperplasia.
Yeah, congenital adrenal hyperplasia. Good. So we need to check for that, right? You have to check serum electrolytes, sugars. You have to check for hyperpigmentation, blood pressure, all those things to see whether it's there in the baby. Right. Then you have to check the femorals in the baby. So you keep your hands on either side of the inguinal canal and you feel the femorals. You can check both at the same time. But this is our screening when we are checking for the femorals. Yes, what disease are we looking for? We are screening
coarctation.
for... Very good. It's coarctation of aorta. Then we come to the hip examination, right? So we have to hold the baby. You have to flex the hips and flex the knees. Hold it within your thumb and index fingers. And then your third finger should be touching the ischial tuberosity, right? So you can abduct both legs at the same time. The femur should be parallel to the ground. And if you can do it without resistance, that means the hip is not dislocated. Then you adduct it and push it back and see whether the femoral head slides through the acetabulum or not. That's a Barlow maneuver. That will see whether there is a dislocatable hip. So we check to see whether the hip is already dislocated using the Ottolani maneuver and whether there is a dislocatable hip using the Barlow maneuver. Right, so here's a real life picture. This is not very comfortable for the baby, so you should not try this at the beginning of the examination because you are most likely to upset the baby. Right, so there you see there is abduction of the hips and it's almost parallel to the surface, so which means this baby is not having a dislocation. Here the hips are being brought close together, adducted to check for whether there is a dislocatable hip. Right, so from hips we go to the area of the sacral dimple, right? You can see there's slight bluish discoloration here and slight depression. That may be normal, but sometimes there can be a sinus tract if you can't see the depth. And you also look to see whether the anus is present. Can someone tell me what do you call this bluish discoloration you are seeing here in some places? Very common in Asian babies. The picture is not of Asian baby.
Mongolian blue spots.
Yeah, so that's very common, right? So you stretch the skin around the sacral dimple and you also check to see whether the anus is present. So again, you can see here it's not very clear whether it is a dimple or it may be even a sinus tract. So if you feel you can't see the depth of it, you will have to ask for an ultrasound scan, right? And see whether there is any connection to the spinal cord or not. Okay, and then you've taken off the nappy. If there's stool in the nappy, what is this stool called? Yes? Newborn stool, this is. What do you call this? This is what it looks like in the first few days. It's called meconium, right? It's greenish, black in color. Very sticky, very difficult to wash. It's normal stool for a newborn in the first 2-3 days. This again is stool of a newborn. This is kind of golden color stool which you see after breastfeeding is established. Right? So by having a look at the stool, you can basically tell the age of the baby and also whether breastfeeding has been established or not also. Okay, so then you put the nappy back. So once you remove the nappy, you look at whether there is, if it's a boy, the testis and the placement of the urethra for hypoepispadias. In a girl, ambiguous genitalia. Then you have to check the femorals. You have to check the hips. You have to check the sacral dimple and you have to check for the anus. Right? And if they have passed urine or stool, you can comment on that. If it is very dark, concentrated, that might mean the baby is really not established breastfeeding and needs support. Then we move on to the head to toe examination, right? So you cup the baby's head between the two palms and feel for the suture lines and the fontanelles. You look to see whether there is separation of sutures like in hydrocephalus overriding of sutures like in craniosynostosis where the bones are overlapping. Then you also check the size of the fontanelle. Are they big like in macrocephaly, hydrocephalus? Are they small as in microcephaly? Then you also have to check the occipitofrontal circumference, and you should look for lumps and bumps like cephalohematomas. What is this? Or caput. Can you see the head of this baby? Can someone tell me what it is? What you can see? What can you see here? Yes? What are these bumps-like things on the head? Yeah. Can someone quickly say what it is? Yes, come on, hurry up. So this is what a cephalohematoma looks like, right? It is bound by the bone, right? Because it's a subperiosteal bleed. This is bound by the parietal bones. That is why it has that funny shape. So this is a cephalohematoma. Whereas this would be most probably a caput, where you can see it's a subcutaneous swelling and it's not bound by the bone. So therefore it can cross the midline. Right? So here you can see different layers of hemorrhage. Caput is a subcutaneous thing. You can see it inside the skin. It's not bound by anything. The skin is continuous. So it can cross the midline. Cephalohematoma is bound by the particular bone. It's a subperiosteal bleed. So it will be limited by the bone, and therefore, if you remember the arrangement of skull bones, they don't cross the midline. They are neatly arranged on either side. Right. Then you learned during the nutrition, growth and development module that the head should be measured, right? So therefore, the head should be measured. The occipital circumference should be measured once you feel the head. Then with the head comes checking the eyes. So if the baby's eyes are open, you shine the ophthalmoscope and you look for what is called the red reflex. You should be about 20 centimeters away from the baby. If the baby is not opening the eyes, one way of opening the eyes is lifting the baby up like we have showed in the picture. And you come from the back and you shine it at the baby's open eyes. Right? So what can you see? The baby is lying down, trying to forcibly open the eyes. Generally not a good idea because they try to forcibly shut it. So what happens? When you shine the light will go through the cornea. Right? And it will, if the lens is transparent, it should go into the retina, right? And we should be able to see the blood vessels of the retina. So what we are checking with the red reflex is whether the lens is transparent or not. We are basically screening for cataract. Red means when you see a blood vessel, it will appear red. So that is what we mean. Right, so this is what you will see through the ophthalmoscope. You will see a red light in each eye, and that is called red reflex, and that is normal. Right, but here in this picture, can someone tell me why one side is white? That is, the white side is abnormal. It is called white reflex. When does that happen?
Congenital cataract.
Good. So if the lens is opaque, you cannot see the retina. So you cannot see any red color. And the whiteness or the opacity of the cataract is seen. So retinoblastoma can also cause a similar picture, but this is mainly screening for congenital cataract. So then you have to look at the face of the baby for features of Down syndrome. Right? Here you can see some features. Flat nasal bridge, short neck, right? Epicanthic folds. You don't really see much of upward slanting eyes. So you have to be familiar with the features of Down syndrome. Can someone tell me what this is? So this is a baby with another trisomy. Any guesses?
Edwards syndrome.
Yes, that's a baby with a very prominent occiput, low set tears, small chin. It is Edwards syndrome. Good. And then we have to have a look at the baby's mouth, looking for cleft palate, right? So here what you can see is there's opening of the palate. This baby is having a cleft palate. So once you look at that, we have to look at the neck, right? Midline lumps for thyroid thyroglossal cyst and side for sternocleidomastoid tumors, cystic hygromas, and such branchial cysts and such tumors. You have to extend the neck in the midline as well as check each side. Once you do that, we come to the hands and the feet. So here you can see, can you see an extra finger there? That's polydactyly. You have to count the 5 fingers, check whether there are extra fingers, which we call polydactyly, or fingers which are bound together, which we call syndactyly. At the same time, you can check the palmar reflex. Then in the feet, you can see these both feet. You again count how many toes are there, whether there is polydactyly or syndactyly, and check whether there is what you call club foot or Thelypus equinovarus, where you can see the feet are bent towards each other, right? So that will need referral to the orthopedic surgeon, where initially they will do sort of plastering and casting, and if it doesn't work, it will have to be corrected with surgery. So early correction is important before the baby learns to walk, right? So immediate referral and correction is needed, because if you remember, they start walking around, standing around 9-10 months. So correction has to be completed before that time. Then neonatal reflexes. We have done this during the nutrition, growth and development module. Can someone tell me what is this reflex quickly? Yes? This would be the plantar reflex, right? Where you keep the thumb on the baby's feet. And this would be the Moro reflex, right? Where you sort of give the baby a little startle. I will demonstrate this when you come for your pediatric, neonatal appointment. You will be having hands-on experience in eliciting this and examining the baby. And what is this reflex? This is the palmar grasp reflex, right? We did all this during the nutrition, growth and development module. This one is the rooting reflex, where you touch a side of the face. This is the sucking reflex. You don't have to elicit everything. You can elicit at least when you're checking the hands and the feet. Palmar reflex, plantar reflex are easy to elicit, and Moro reflex you have to know how to elicit, because it gives lots of information. Right, and that is the walking reflex, and again the Moro reflex, right? So the last bit is, there are some benign lesions which you need to know, right? This is called erythema toxicum. You can read a bit about it in the illustrated pediatrics. It has a little yellow center and it's surrounded by red. These are called stalk bites, right? It is found at the back of the neck. You can see it in the middle of the face, on top of the eyelids. Those are all benign lesions. This is a conjunctival hemorrhage, again common in newborns, but it should be documented, because if it comes later, it may be feature of child abuse. Then Mongolian blue spots, right? So there are many benign skin lesions in the neonate, which you should read a little bit about. This one is a pustule, right? That is not a benign lesion. It is an infection which needs to be treated. So before we discharge a neonate, we have to make sure the newborn exam is completed, baby has passed stool, baby has passed urine, that the breastfeeding has been established, which we talked about in the nutrition module, and neonatal screening is done, and we have to also tell when to seek medical advice. So 3 screening tests are done, which I am not going to give you details, right? This is the screening test for congenital hypothyroidism, right? Heel prick test, where the blood is taken onto a filter paper, dried and posted to MRI, where they will check the TSH. And every baby born in our country undergoes this test for congenital hypothyroidism. Then every baby also undergoes pulse oximetry to check for critical congenital heart disease. So the saturation should be more than 95%. in both hands and the feet. And there should be no difference between the preductal and postductal saturation. We'll talk a little bit more about it in the respiratory distress lecture. The third screening test is newborn hearing screening, right? So otoacoustic emission is done in all babies. It's not done in our hospital because of a problem with the machine, right? And every baby. So universally around the country, all babies should have this hearing screen, pulse oximetry, and the heel prick test for congenital hypothyroidism, right? And before discharge, we must make sure the baby has established breastfeeding. Okay, that's it. Thank you. I think we finished a little late. Unless there are any burning questions, we will conclude. Are there any burning questions? Or you can ask me the next time I do a lecture for you. Yes? Okay then. You can join the next lecture. Thank you.